Honorable Chairperson, respected panel of experts, and my dear learned audience, Assalamu alaikum. I am Dr. Mohammad Ali working at Ibn Sina Medical College Hospital as assistant professor. My case is Mr. X, 54 years old, hypertensive diabetic patient presented to us with the complaint of increased exertional shortness of breath for last 4 months. He was a chain smoker and had a strong family history of coronary artery disease, and he was a history of non-STMI 13 years back. During this time, he doped CAG and PCI to meet LAD, meet LCX, and proximal OM2. But again, patient present with post-PCI angina on 2014. During this time, CAG showed 80 to 90% ISR in meet LAD, 100% ISR in meet LCX, and newly developed 80 to 85% stenosis in proximal and distal RCA. During this time, advised CAVG, but patient deny. Again, do PCI to proximal, PCI to LAD and proximal and distal RCA. Patient present again on an STMI on 2019. Again, CAG was done and it showed the 75% cutoff lesion in proximal LAD, 95% lesion in distal LAD, and pattern stent in mid LAD. Again, patient advised CAVG, but patient denied. Then PCI to proximal and distal LAD was done. Patient was hemodynamically stable. ECG showed LVS with stent. Echocardiography showed concentric LVS with no regional wall motion abnormality with normal ejection fraction. So regarding the timeline of previous stenting, 3 stent in 2009 and 3 stent in 2014 and again 2 stent in 2019. So total 8 stent has been placed. And in mid LAD, there is a 4 stent, and mid LAD has double layer of stenting. Again, patient present with symptom. So what we suspected? So let's go to angiogram. The angiogram showed that the LAD is totally occluded from proximal part. And LCX is type non-dominant vessel, pattern stent is OM2 with mild ISR. And RCA is dominant vessel. Mid and distal RCA had pattern stent with mild ISR and retrograde field from the RCA. LAD is retrofilled by the right system. So depending on the angiogram, we do the synthesis score. Depending on the synthesis score, the first option is a CAVG. And we offer the second option, open the CTU in a center where IVAS or ROTA available. We consult with the patient, but patient said he never give up the smoking. He will never go for the CAVG. And he denied the ROTA due to financial limitation. And he also said, what you can do or give some medicine, I will go back to home. So in this scenario, what I should do? So I make my plan. I open up CTU with my logistic support and we prepare the bed. Depending on the bed preparation, we go for DCV or extending. So according to our plan, we negotiate the left system with EVU3 catheter and we advance the fine cross through the fluffy wire, and then we change the fluffy wire to pilot 150, and after several attempts we try to open the CTU lesion, and then we advance the fine cross microcatheter. We remove the pilot 50 wire with then we took the body wire and then we dilated the lesion with 1.5 into 10 semi-compliant balloon from proximal to mid LAD. And it was inflated at 14 atm pressure. And after, there is a still residual stenosis, significant stenosis from proximal and mid LAD. Then we took 2.10 NC balloon and it was inflated at higher pressure from proximal to mid. And then we took 2.5 into 10 millimeter ball valve cutting balloon and it was inflated from the proximal and mid LAD. And after then, the result showed that mid LAD was flow is significantly improved, but is still significant lesion in the proximal LAD. So depending on the bed preparation, there is a reduced residual stenosis less than 30% in mid LAD. So we decided to give a drug-eluting balloon in mid LAD, and there is still more than 30% residual stenosis in the proximal LAD. So we decided to give a stent in the proximal LAD. So according to our plan, we give 2.75 into 20 millimeter DCV in the distal LED, and it was inflated, and give 3 into 28 millimeter S10 in osteoproximal to proximal LED. And after then, the result was satisfactory. We post-dilated the LED lesion with 3 into 10 millimeter NC balloon at higher pressure. But after then, there is still dog bone effect in the mid LED. Then we took 3 into 10 millimeter OPN NC balloon, and it was inflated at higher pressure, which was 35 atm pressure. And then the result was quite satisfactory. Sorry, it was not running.
Just move on to the next slide.
So after then, we accelerate the lifestyle modification. We change the drug, and we do the CAVG. We do the check angiogram after. We do the check angiogram after 2 years, and it showed the fluid is quite good with mild residual stenosis in the distal part.
Your time is up.
Sorry,
I'd like to invite
sorry, it's not moving.
persons for some questions now.
Okay, thank you.